This podcast is brought to you by ProLongevity, the award-winning 8-week program that can transform the lives of people with prediabetes, type 2 diabetes, and many other lifestyle-related illnesses. Founded by Phillips, the pharmacist who gave up drugs.
Good morning, everyone, and welcome to another edition of the ProLongevity podcast. And I'm absolutely delighted to have two star guests with me today, both colleagues from the Public Health Collaboration, and that is going to be the major focus of our discussion today, as well as the obvious health ramifications. I have with me not only Sam Feltham, who essentially runs the Public Health Collaboration, but our old friend and crusading cardiologist, Aseem Malhotra. And I thought we might start off with some basics in both your cases, perhaps starting first with you, Aseem, because as we've discussed in previous podcasts, my training was very conventional, and yet I've ended up in a completely different place, and I now style myself as the pharmacist that gave up drugs. And to some extent, I would say you're the cardiologist that gave up not only drugs, but many of the unnecessary interventions. So perhaps you just outline your own personal health journey and how you ended up in this place when, as I said, you could have made a very comfortable living as a conventional interventional cardiologist without a lot of the SH1 that you have to put up with as a result of challenging the norms.
Yeah, thanks, Graham. Yeah, so I think my thinking has evolved into how I would articulate my journey, looking back on it. I went to a very good medical school. I trained in Edinburgh. I graduated in 2001. So I've been a qualified doctor now for almost 21 years. And I decided even before I went to medical school that I wanted to become a cardiologist. And part of the reason for that is because two very close relatives at that time had died prematurely. My grandfather got a very rare condition at the age of 60, having been a very fit guy, used to play tennis, very fit guy, died at the age of 60 from something called cardiac amyloidosis. And then not a few years after that, my older brother, he died at the age of 13. He went into crashing heart failure, having probably got viral myocarditis at the time. So there was that in interest, certainly in all things related to the heart. Both my parents were GPs as well, so medicine ran in the family, it was something that I always had an interest in. And then once I went to medical school, of course, then my interest only became enhanced, if you like, and partly because we know, and it's still the case, heart disease is still the biggest killer in the Western world. I found the heart very interesting. I found in particular interventional cardiology very interesting, which is for lay people routine heart surgery. And my early training in cardiology was in that. But one thing that I think I was very much aware of as observing as a clinician, having worked in many different hospitals around the country, having, always keeping up to date with research, getting involved in research myself, was that we still had this worsening burden of chronic disease, more stress on the NHS, which isn't just bad for patients and the public, of course, because our duty as doctors ultimately is to reduce suffering, but also it was causing more stress amongst colleagues, because as you know, if you're working in an overstretched system, then your job itself becomes less enjoyable. And we wanted to be in a situation, yes, we're doing something to help others, but it became unmanageable. So I started on this journey to try and figure out what was going wrong, and it very clearly it didn't take long for me to realize that most of these problems were driven by lifestyle, primarily in the hierarchy, poor diet. And that's where I became a campaigner, which was, I started on that journey over 10 years ago, writing articles in mainstream newspapers, especially The Guardian, The Observer. And then that evolved into medical journals, many sort of hard-hitting, well-publicized articles in the British Medical Journal. And that's really where, it's taken me. And I've gone down this road where, you keep learning all the time. I'm always someone that, I find that I need to be learning something new every day. So I always keep up to date with evidence. But also for me, my ultimate goal as a doctor really is, acquiring knowledge for the purpose of reducing human suffering. But the problem is that knowledge has to be complete and it has to be truthful. And if that knowledge is incomplete and not truthful, which is what a lot of doctors and the public are dealing with at the moment, biased information, then you're going to get bad outcomes. And to some degree, if not for most to a large degree, we have got pretty bad outcomes right now in the world when it comes to our healthcare system, when it comes to chronic disease. And at the root of that is biased information that's just being disseminated through lots of different media, including mainstream media, that ultimately serves the purpose of just helping those very people that are trying to make money out of misinforming people. So really, that's at the core of my drive to try and campaign to change that, those system failures, those structural problems, so that we give people the best opportunity to live the lives that they want to lead, especially when it comes to mental and physical health.
Now, obviously, with having undergone full medical training and then a cardiology speciality, and I'm a generalist, obviously, we're all born in this escalating milieu of cardiovascular disease, type 2 diabetes, cancer, etc., etc. And we've all witnessed, in our professional lifetimes, I've been, doing it longer than you have, this escalation. In any of your training, Aseem, was there ever any discussion of the trajectory of this descending poor public health and root cause?
No, not at all. Not at all. I think that one of the things that I learned, which was very useful for me in Edinburgh, which has a very strong, it does have a very strong focus in medical training around public health, was one thing that struck me early on, though, was the impact of smoking reduction. And we know that has had a massive impact on reduction in cardiovascular death. And I still think that's a hugely important learning point as we move forward, is that when legislation was introduced that really tackled the environment around smoking through availability, affordability, and acceptability, then that's when we saw a massive reduction in smoking prevalence, which was about 50% of the population in the 1960s. In terms of adults, about 17%. So, and that was more than anything else has had the biggest impact in reduction in death rates, people dying from heart disease. And that was something that I think that stayed with me, even before I became more enlightened on the diet issue. I knew that when I was giving ward rounds to people after they had heart attacks in the hospital, the thing I would always tell them is that them stopping smoking, if they were smokers, of course, had a much bigger impact on their longevity and reducing risk of heart attack than all the medications, cocktail of medications we gave them combined.
Yes, I remember, because this was in the Blair years, that Blair was not as rapid at banning smoking in public places as we all expected. And there was always controversy about the delay and where some of the money was coming through. And the smoking ban happened in Scotland much before, I think a good 2 or 3 years before it happened in England. And when they introduced the smoking ban, there was an astronomical and significant reduction in heart attacks and strokes. And it happened very, very rapidly. And no one foresaw it. And there was a belief, well, maybe it's a small population, maybe it's an artifact. Because we've always believed that there are benefits of stopping smoking, but they accrue over time, not so rapidly. And what was also equally interesting is when they introduced the smoking ban in England, they saw exactly the same result, which I think has convinced us all this isn't an artifact, this is genuine. So turning to you then, Sam, because you've also had your own personal health journey, starting as quite a young man. I've just been listening again to your 21-day challenge. Perhaps we'll talk about that. But what is your journey that's led you to this interesting place?
Yeah, my journey's been quite a varied one, let's say. I'd say my interest in health probably began when I was 13, and I was diagnosed with Hodgkin's disease, actually. And for anybody that's met me in person, they'll always see this scar on the side of my neck here. That's where I had the lymph node there biopsied, and then diagnosed with Hodgkin's disease. 4.5 months of chemo later, I was clear. But that was quite an experience, because the lymph node there was actually about the size of a small egg. And it's fairly common in pubescent boys for glands to flare up and things like that. But my mum really had to push the GP to get it biopsied. And he said, it's nothing. He's going through puberty and all that jazz. And then it turned out, it was a mild cancer, basically, early stage cancer. That was quite an experience to see that, right, you've got this, official doctor sitting across from you, and he was wrong, basically. And my mum was right, which is more often than not. In her
Very
case,
interesting. Any decent clinician will tell you always trust mother's instincts. And as soon as you become a clinician that doesn't do that, I think you've become arrogant and removed from the reality. So I think there's a lesson there for every clinician.
Definitely, absolutely. And then from there, I've always been very active. And at university, I was on the hockey team, and then post-university, I decided to kind of go on a somewhat gap year, which ended up being a gap 4.5 years-ish. And I became a snowboard instructor. I trained in New Zealand and kind of went from Northern Hemisphere to Southern Hemisphere, back-to-back winters for 8 seasons in a row. And that was absolutely fantastic. But it was in my last season in Banff in Canada that I decided that I wanted to take my health to the next level, because I'd done, 4 years of partying, basically. And 4 years of partying on your health doesn't do you well, essentially. So on
in a typical high carb, high beer diet, would it?
Yes, pretty much.
Lots of
chips, lots of pasties. Just when you're on the hill, you just grab whatever junk they're selling in the cafes and things like that. You didn't think about it really.
Aseem always says you can't outrun a bad diet. So was it obvious, or were you so sort of burning so much energy that from an outside perspective, no one would have known?
Oh yeah, no. From an outside perspective, it was nobody would have known, definitely. And what was interesting was this last season that I had in Banff, when I did change everything. I gave up alcohol on January 1st, 2010, and I've been sober ever since, basically. And during that time as well, I really started to dial in my nutrition as well. I took my own food on the mountain and things like that. It made a massive difference, and particularly in my asthma as well. So I'd had asthma since I was a child, and it would flare up now and again. And then, shifting to a low carb real food diet, all of those symptoms were alleviated, essentially. And particularly when you're at altitude and you've got low oxygen levels, that makes a massive difference. I just wish I'd done it earlier, obviously.
So you didn't. What led you to this kind of low carb? I mean, obviously, everyone knows that a diet full of just McDonald's and chips and beer is not healthy. But most people then wouldn't go where you went. So what led you to that place at that time?
So 2010 was actually the time when Gary Taubes' Why We Get Fat came out. And that's basically an abridged version of Good Calories, Bad Calories. I just came across that, read that, and I thought, wow, this makes so much sense. And implemented that, and the proof is in the sugar-free pudding, basically. And I just felt so good. And as a result of that, at the end of that season, I decided that I wanted to move into health. And being a personal trainer was something that I really wanted to pursue. And so I trained at the European Institute of Fitness as a master personal trainer. Over in June 2010, I moved in with my brother in London, in a box room. And over the next 5 years, I built this fitness business called Smash the Fat, fitness and fat loss boot camps. And we ended up with 10 locations around the country. But as part of that, I had a YouTube show and a podcast, which is still available online, which you can watch. But during that period as well, I did these self-experiments that you were referring to earlier, these overfeeding self-experiments, where I did 3 different diets over 3 weeks each, with 3 months in between, kind of have a biochemical reset. First one was low carb real food. Second one was low fat fake food. And the last one was high carb, very low fat, vegan food, basically. And on that first one,
a bit more detail of that, because I think that's fascinating.
Yeah, totally. So, I mean, the idea was that I was going to eat twice as much as I usually would on all 3 of these diets and see what happens. And I tried to match up the net calorie surplus as much as possible. So on the first one, I ended up eating 47,000 calories net surplus. And that should have equaled 6.1 kilograms of weight gain. But I only actually put on 1.3 kilograms on the low carb real food diet when I was overeating. I actually lost 3 centimeters from my waist. And then on this second one, the low fat fake food, again, I ended up in a 47,000 calorie surplus, should have been 6.1 kilograms of weight gain, but ended up being 7.1 kilograms of weight gain, and put on 9.25 centimeters around my waist, which was absolutely mind blowing. Thankfully, Aseem was on call on those, and he looked at my bloods during that time, and kind of he said that I effectively gave myself metabolic syndrome as a result of that second experiment, which was less.
It just shows you that you can give yourself metabolic syndrome in 3 weeks and potentially lose it in 3 weeks.
Yeah, exactly. So what was interesting is that following on from that second experiment, I did kind of like an experiment 2B, where I decided that I'd eat at calorie maintenance, which was about 3,500 calories, but shift back to my usual low carb real food diet. And even though I was trying to maintain this weight gain, what happened was that I actually lost 6.1 kilograms of the 7.1 kilograms that I'd actually put on. So despite the fact that I was trying to maintain this weight gain and calculating it with the protein, thermogenic effect, the loss of fiber, and also any exercise I was doing, it still, plummeted, shifting back to low carb real food. And then this last one, so very low fat, high carb, vegan food. So on this one, I ended up just having a 40,000 calorie surplus. And that's because of the amount of fiber that I was eating. The recommended at the moment, I think it's 30 at the moment, isn't it? That they recommend on fiber, but I was eating 175 grams of fiber a day, and so there was a massive loss of calories from that. So that's why it was only 40,000. But yeah, it being 40,000 should have just been 5.2 kilograms of weight gain, but I put on 4.7 kilograms, so just shy of the calorie formula there. But I actually put on 7.75 centimeters around my waist as a result of that, which is pretty shocking, really, considering that I was eating over 3 weeks, but 7,000 calories less than that first one, where I only put on 1.3, but lost 3 centimeters around my waist. So it was really a demonstration of, how the calorie formula certainly isn't it doesn't really apply when you apply it to an open biochemical system like the human body. Thankfully, just last year, alongside Dr. Eric Westman, we managed to publish it in the peer-reviewed literature. So if you just Google Sam Feltham overfeeding experiment, then it'll probably come up. Or search that on PubMed, and it'll come up.
No, we'll do that. We're going to, in the show notes, we'll, and I've just been reading all those just as a refresh before we met again today, and we'll link to all that in the show notes. Because you kind of think, well, that's job done then, right? You've proved that a calorie isn't as a calorie. Aseem's shown us all that it's, cardiology is mainly about public health and prevention. So we can all go home because it's job done, right?
Yeah, that's it. Once you've proven your point, you don't need to, do any follow-up with trying to convince people that they've been wrong for 34 years. And
once you see this, from all our perspectives, I always say it's completely impossible to unsee it. Mm-hmm. Yeah. And, I've been practicing in this way. Well, I probably started 10 years ago, but in earnest the last 5 years. And once you see the changes and the rapidity of the change and the relative ease and logic behind it, it's simply impossible to go back to the old way of practicing. Mm-hmm. Which kind of begs a question. I mean, we've proven something here, haven't we, between the three of us, in our back rooms. Why is the world not moving on? Because it's not that difficult, is it?
It's really difficult to understand why you demonstrate these things and then people can't fully connect the dots, or they don't feel like there's enough evidence to move on, basically. And I mean that's partially why we set up the PHC as well, is to really fly the flag for this movement, because it does need that, because even though you show people that there is a black swan, it exists, right? You repeatedly have to show that there's a whole flock of black swans out there, so that then they'll actually start to believe that there are actually black swans, basically, and that's what the PHC is kind of doing.
So that, which segues neatly into the main theme of today, which is the PHC. So tell us a little bit about how PHC came into being, what your role is within PHC.
So late 2015, I was becoming increasingly frustrated with the dietary guidelines that my clients were getting. Essentially, that being the Eat Well plate at the time, and then them coming to me and then me having to explain, well, this is what they're presenting, but it's not evidence, and it's not what actually works. And so out of that frustration, and because I'd interviewed the likes of Aseem, then I decided that I'd pitch this idea of setting up a charity that would focus on changing dietary guidelines for the better, just in the UK, to start with, at least. I pitched this idea to Aseem, to Joanne McCormick, Ian Lake, David Unwin, Jen Unwin, Trudy Deacon, and everybody that's on the scientific advisory board today. And they said, yeah, great idea, but where's the money going to come from? Which is always the question you've got to ask yourself. Thankfully, we ran an online crowdfunding campaign in February 2016, doubled our target within the month. And then from March 2016, I closed down my fitness business, helped the coaches that I had on board transition into their own businesses. But then, from that point on, Smash the Fat was no longer, and Public Health Collaboration became an organisation trying to fly the flag for better lifestyle to improve public health, essentially. And my role from then on, director of the Public Health Collaboration.
So that's quite a big deal, really. Just like Aseem could have carried on making a very nice living as a conventional interventional cardiologist, stenting people and handing out statins, etc. You presumably had quite a successful multi-site business, which you closed to do this. So that's real commitment and vision, and I think it should be commended. So presumably your motivation first and foremost wasn't a question of follow the money, honey, but to try and do some public good.
100%. Yeah. What was really good at the European Institute of Fitness is that they tried to, they encouraged you to come up with kind of a vision statement, a vision and mission statement, really. And mine ended up being to help as many people obtain and maintain a healthy lifestyle. And I've been sticking to that ever since my training in 2016. 2010 rather, sorry. Gosh, how time flies. 2016 was the start.
Yeah.
So it's been 12 years since I came up with that, personal purpose. And that's what I've been sticking to. And I will be sticking to that for the rest of my life, just helping people obtain and maintain a healthy lifestyle.
So paint a picture of us you set this thing up, and then what happened? Because, you've got to turn that into something and then grow it. So what has been the kind of journey of the PHC, from day one to today, including Aseem's growing involvement? And then let's talk about kind of paint a picture where we are today, but where we hope to be in the future.
Yeah, totally. So March 2016 is when we kind of officially launched post crowdfunding campaign. And then it was just, I don't know if it was, the stars were aligned or something, but literally March 2016, Public Health England released the new version of the Eat Well plate, which is now called the Eat Well Guide. And it was really an opportunity for us to kind of come out all guns blazing and kind of saying, well, you've basically just rehashed what you've done before, and that wasn't based on anything in the first place.
Slightly less badly played. Would you put it slightly less badly?
Ever so slightly.
Yeah.
Because they moved all of the junk food off of the plate and into the corner of the graphic. That was basically it. We put together a couple of reports by May 2016, one of which was our own healthy eating guidelines and weight loss advice report, which critiqued the government healthy eating guidelines and weight loss advice and presented our own versions, that being the Real Food Lifestyle. And then at the same time, Aseem wrote this hard-hitting report on eat carbs, cut carbs rather, cut carbs, stop snacking, and what was the last one again, Aseem? Sorry, what was the full title again? It was cut.
I think
carbs,
it was eat fat, cut the carbs, to reverse type 2 diabetes.
Yeah,
to lose weight and reverse type 2 diabetes.
Yes, that was it.
Yeah.
Fantastic report that came out with 10 points on what we need to be tackling, and both of those reports are available on the website today, and that really launched us initially. And it was a bit of a big media blast. Even Public Health England had to release a press release kind of saying that we're completely irresponsible for saying that people shouldn't be cutting carbs.
Spreading dangerous information by telling people to eat fat. Dangerous. You're going to be killing people.
Encouraging people to eat real food and avoid fake food.
I mean, now you look at it and you think, what a load of absolute nonsense. But,
Yeah, what's sad is they still believe it, although we've moved the goalpost slightly. Yeah. So, I've been following PHC. I think what drew me in originally was either Aseem or David Unwin, can't remember. And I've been involved with it, I think, since 2017. So relatively early days.
Yeah, absolutely. And it's been quite a journey, like the past coming up 6 years, and we've learned a lot of lessons, haven't we, Aseem? In trying to create the approach that we've got today, but essentially our current approach to improving public health is through various projects. One being the Ambassadors Programme, of which you're part of, Graham, thankfully, and they're local representatives of the PHC trying to liaise with local healthcare professionals and inform them about what we're doing it, why we're doing it, and how we can help them as well. And the main way that we're trying to help them is by setting up free lifestyle support groups for their patients to attend. So we're trying to work with local NHS GP practices to help give their patients good lifestyle information, basically. And then other projects include one set up by Jen Unwin, Dr. Jen Unwin, who's our in-house clinical psychologist, which is food addiction resources, and that's focusing on the issues of food addiction, obviously. And then another one is called Collaboration with Kids, which is still in the early stages, which is set up by Dr. Ian Lake, who is one of our advisory board members, and that's alongside Heidi Giver, who's a nutritional therapist, and obviously that's just focusing on improving the living environment for children in terms of being able to improve their health. And then the penultimate one is the Lifestyle Club, which is our service for people to put their type 2 diabetes into remission through the NHS. So we're starting to get commissioned for that. People can check that out at the lifestyleclub.uk, and we're only commissioning this through the NHS, so unfortunately you can't kind of just buy into it straight away. But what you can do is you can recommend it to your GP practice, and then they can start the ball rolling with a pilot through us, essentially in their GP practice. And we're hoping that to be a major cog in the wheels of change in the NHS. But then the last one is the Scientific Advisory Board, and that was our first approach to it. And moving forward, that's going to be a massive part of the change we're hoping to implement, which is chaired by Aseem, which is amazing to have Aseem as the chair of that scientific advisory board, and he gives a tremendous amount of time and effort in order to fly the flag for this movement. But essentially, that is the where we're hoping to make a big impact in terms of government policy, basically, be influential in that regard, and really get it going from the top down. And as you alluded to earlier, one of the biggest public health wins is smoking reduction, and that only happened through policy. So hopefully the advocacy that we're doing with the Scientific Advisory Board, led by Aseem, is going to be, how we're going to majorly tackle this on a big national level. So
give me a sense of, we started in 2015-16 with you presenting an idea to a few people who said, great idea, go and do it. To where are we today with, as of today, how many ambassadors are there? What's the sense of the scale of it now?
So we started the Ambassadors Programme in September 2017, so it wasn't a year until we kind of came up with that idea, and we're now up to 300. So we've got 300 ambassadors across the country, we're increasing our size year on year, and you can actually read our Charity Commission's annual report for 2020-2021, which was just published yesterday, in fact, on the Charity Commission website, which kind of gives you a better idea of what we've been doing, and where we're headed as well, and the growth that we're starting to see.
So, Aseem, give us some perspective on this, because you've also been very much involved in the journey. And I never know which country I'm going to find you in from one moment to the next, because you're not just crusading in the UK, you appear to be circling the earth crusading. So what's your take on all of this, and where we are, what we've achieved to date, and what the future could look like?
Yeah, Graham, the first thing I'd like to say is I don't think we can underestimate to any degree the amount of effort, work, time, and success that Sam has really brought to this, to the PHC with his sort of his vision, his drive. It's not an easy thing. It's something I've done over the years to coordinate and get many people to come together and get the right people to come together. And originally, from my perspective, I was always happy to help Sam in any way I could. But what I brought to the table at the beginning, certainly with many others involved in this, whether it's David Unwin or Joanne or Ian, is that we were essentially, sharing our knowledge as doctors, as clinicians, in a forum with members of the public, with patients. And that's how it grew. And those conferences that, Sam was organizing every year just became bigger and better. We've had some fantastic international speakers, from people like Jason Fung to Tim Noakes to Robert Lustig, who've also come to the conferences on a yearly basis. I think, I don't know whether we're allowed to say who the next one is. I'll let Sam tell everybody if that's appropriate right now. But we've got a fantastic international speaker coming to the conference in a few months' time, and I think that as that grew, it came to a point, now we need to try and really formalize it in a way that we can be a very effective organization, campaigning organization. Of course, we had some, we had a little bit of a appetizer, if you like, of what we could achieve with that report on, let's let low carb essentially be the main primary approach to reverse type 2 diabetes. And, I was very heavily involved with many other people in coordinating that to get it into the mainstream media. And it was massive news. It was news. It was national news headlines. It was in several newspapers, caused a lot of debate and discussion, and it shifted the debate forward in a good way. So I think we've achieved a lot already. And now I think we're at the stage where, okay, well, how do we actually do what the name of our organization suggests, public health collaboration? So really bringing together something that's missing in a lot of charities is, especially in health charities, is that you don't have that real collaboration between healthcare professionals and patients and members of the public. Ultimately, our duty is to serve the public, right? So a lot of other charities, without naming them, don't really have much patient and public representation. So I think that's one of our great advantages. We have people from primary care, secondary care, we have pharmacists, we have nurses, we have people in all different allied healthcare specialities coming together, sharing wisdom and knowledge with the purpose of improving public health. And I think if we start even from the basic definition, the World Health Organization definition of health, it is a state of complete mental and physical well-being, not merely the absence of disease. So let's just think about that. How do we achieve that? And what are the barriers into improving population health, reversing obesity? I think the diet stuff is very much part and at the forefront of our strategic approach over the next few years. But I think one of the other things, and that's something I'm working on, and we'll discuss more with the other board members and the trustees, is the broader theme of public health, so that as we move forward, and I see this as something that will go on for many years, even decades, okay? Because there's a lot of work to be done, but there are lots of other areas other than purely just focusing on diet in public health that are also important. Very simple things like, are people getting, are they getting enough, are they earning enough in their jobs to allow them to lead the lives they want to lead when it comes to their health? Because psychosocial stress, people working in high demand, low paid, low control jobs, that in itself is a huge risk factor for premature death and disease. So we have to think about those things as well to have, so we actually do justice to the name of the organization, Public Health Collaboration.
I completely agree. I mean, as a community pharmacist, I know we're generally seen as people who supply medication, but I've always seen the use of a medicine as a public health intervention alongside lots of other public health interventions, and you can choose to spend the money in that way or in another way. And I would like the community pharmacy network to be viewed as a public health network. The fact that we see, nearly 2 million people a day on a health-related matter in terms of opportunities to see and influence is huge. And I, as you may know, was involved from the early days of setting something up called Healthy Living Pharmacy. And there are now, the vast majority of UK pharmacies are now accredited Healthy Living pharmacies. So you can't simply decide to be one day, tick a box and get paid for it. You have to go through fairly stringent qualifications. The pharmacist and the team need to learn stuff and be seen to do stuff and keep up to the mark. So it's quite structured. I suppose the start of the journey for me, actually, you mentioned earlier on, was smoking cessation. So in the Thatcher days, when nicotine replacement therapy was first available, the view of Thatcher and the Thatcher NHS at that time was smoking is something you bring on yourself. The NHS is not going to get involved with it. It's a self-inflicted problem. So nicotine replacement therapy was only available through pharmacies. And it was only in the Blair years that the NHS adopted it. And I'd been providing smoking cessation services, I guess, for 10 years by that point. And when they started to commission it locally, I trained the local GPs in smoking cessation, not the other way around. So I see a huge potential role here for community pharmacy to play its part. And I, in the last few months have been very busy for us, not just with ProLongevity, but we're relocating one of the pharmacies and we're trying to take it up to, we're calling it community pharmacy for the 21st century. And in this pharmacy, you will not find any lollipops or 99 pence items. It's all health and health related. It's prescriptions and healthcare exclusively. My partner, as you know, is a GP and she's just retired from her practice. So she's going to be spending regular days there. And we're looking to think about all the ways that we can not just help people get the best of their medication, but as you know, a huge role for pharmacy now is de-prescribing. And I'm busy with my ProLongevity clients, getting them off medication, saving the NHS a fortune. And to put this into some financial perspective, the UK drugs bill now is about £20 billion. The total NHS bill is about 165 billion. And the total bill for UK pharmacy is less than 3 billion. So almost all of the money is going on the drugs and, trying to sort of retether the horse after the horse is bolted, and almost none of the money goes on prevention. I think that we could take Healthy Living Pharmacy from a fairly fledgling, but still quite effective in terms of, for example, smoking cessation and sexual health, into this whole new area. And I'm very interested in this new club, Sam, and the pharmacy is we spent the last few months getting it up and running. It's literally, as we speak here today, it's kind of ready to go. And we've got a big launch in the next month. I'd very much like to see if we can be involved in a more granular way in public health collaboration and implementing some of these services through community pharmacy to create that model.
Absolutely, it's fantastic opportunity that we could utilize, and the more people that have access to this, the better. So let's circle back around to that after we finish this.
Yeah, excellent. So what do you think the future holds for public health collaboration and indeed public health? Because in a sense, I think we're achieving a lot, but the simple sad facts are, not only are people living less healthy lives in this country, but life expectancy in the last few years has gone backwards. So, we see this escalating NHS budget, and I'm passionate about the NHS. I'm not here to knock it, but we've seen this huge increase in budget combined with a basic measure of life expectancy going backwards. Where next?
Sky's the limit, basically. I think, as kind of Aseem alluded to just there, we'd like to expand our list of interventions that we'd like to move into as the charity does grow and we get more resources and people from more varying professions as well, then we can expand into these areas with new ideas as well. The biggest thing is trying to implement prevention into the NHS properly, I think, isn't it?
Absolutely.
And the Lifestyle Club is just the start of that. In terms of dietary, mostly dietary, although obviously we're encouraging physical activity as well. But that's just the start, I think, and that's where I'd like to pass over to the chair of the Scientific Advisory Board, Dr. Aseem Malhotra. What are your thoughts?
So no, all good points, all really important points. So Graham, what I would say is, if what we're ultimately trying to achieve, and Sam said sky's the limit, and I think that's exactly the right way to describe it. We have to be ambitious if we're going to make real changes here. We are really ultimately talking about a public health revolution. How do we achieve that revolution of where we get to where we are reversing obesity, where we're reducing the burden of heart disease, type 2 diabetes, improving people's mental health, physical health. And there's a very nice, elegant concept called the triangle that moves a mountain, which is actually developed in Thailand. And there are three sort of components to that triangle. The first most important one is get the knowledge base right, get the information to be clean and transparent about how does one lead a healthy life? And of course, everything related to that, which is also environment and structures behind it. Then you have other component of the triangle is the political. So you need but at the same time, you need the social movement as well. So you need the grassroots movement and you need the political intervention so that policies can be introduced that enable people to lead those healthy lives and give them the best opportunity to do so. So when you've got a grassroots movement and you have top-down change, where they meet in the middle, that's when you have the revolution. So that's what we're aiming for ultimately. And I think once people understand that concept, then as an organization, as a campaigning group of doctors and healthcare professionals and members of the public, then we can definitely, absolutely achieve that. I think we can achieve that because we have actually got enough of it. It's not that, things are going to keep evolving, but we've got enough information. We've got enough of the knowledge base. We've got enough of the science, as you know, around, deprescribing, improving metabolic health, all that kind of thing. So now the real challenge is how do we translate that into policy change? But at the same time, we need to inform other people that we come across in our own environments, in our own clinics. We need to keep doing that work with individuals so that can help also inform the policymakers and also in keeping with the best available evidence that's there. So, I think we've got the knowledge. It's about putting it all together. One of the things I'm going to be working on and drafting and sharing with other members of the PHC, with the Scientific Advisory Board, where we're going to have input from all different sides, is really a kind of broader theme manifesto, really to cover many of these areas. And even going back to the very basics, even, some philosophy in there, but certainly steeped in science as well, is what does it actually mean to be human? Why don't we just start from the beginning? What do we want to, what do most people want out of their lives? How do they want to lead a healthy life? What do we know the evidence around mental health and what kind of things are people chasing that have been proven, whether it's over-reliance on material gain, well, we know this is not going to be the route to our happiness. So we have to start from that and get that discussion going. It's about finger pointing. I also believe ultimately in real, true democracy and informed democracy, so that this, we make the case so that people can make their own decisions about whether they, our arguments, whether they are strong enough, where people actually collectively say, actually, Yeah, we know that the obesity problem isn't primarily about personal responsibility. We know it's a food environment driven problem. Okay, how do we improve the food environment? What does that mean for the food industry and the types of foods they're producing? How do we ensure that people can afford healthy food? What policy changes are needed? So it's about making that case so that ultimately, actually, the majority of the people would support it. And if the majority of the people support it, then the politicians and the policymakers have no choice but to implement those policy changes. So, there are several moving parts in this that have to be tackled simultaneously.
Fantastic. And I think that's probably a great place to leave it with that forward vision, Aseem. I would just say two things. When I'm very much looking forward to a real live public health collaboration conference this year, not a virtual one. I paid for my tickets, I think 3 years ago, Sam. So
yep, right.
I assume I've still got my space.
100%.
Very much look forward to that. We'll put links to the conference on the website and encourage people to join.
And it's Nina Tyson, just so that everybody knows.
Oh, excellent. Yes, Nina Teicholz. Well, it doesn't get much better than that. That's fantastic. And I would just add, my experience is, medicine can be quite cultish and quite arrogant and, quite unpleasant in some ways. And no one's seen more of the visceral attacks than Aseem at various times when he's challenged the norms. What I enjoy so much about public health collaboration, it's partly that you can see that you're doing good. I can see, the light coming on my clients' eyes, but equally it's the friendly, enabling, camaraderie that we have as a group. So you've got, very, very technically adept people, and you've got lay members of the public all working together. And no one's frightened of voicing an opinion or asking what might seem to be a naive question, because we're all there to support each other. And it's that kind of collaboration, very much the collaboration, which I think makes it so special. So I would like to thank both of you for the amazing work you've done on all our behalves, and also for giving us time today. And I look forward to seeing you both at the conference.
Thank you, Graham.
Yeah, thank you so much, Graham.
If you enjoyed the podcast and want to find out more, join our Wellness and ProLongevity Facebook group. Don't forget to subscribe and follow so you never miss an episode, and maybe share to friends and family who might benefit. Finally, if you think you might need help with diabetes, heart disease, or any of the other diseases we discuss, then book a free consultation with Graham. There's absolutely no charge for this, and we would never put you under any pressure. What do you have to lose? Bye for now, and see you for the next episode.